E adesso continuiamo con la dottoressa Jessica Sun, ematologa e oncologa pediatrica presso la Duke University Medical Center di Durham, USA, che collabora con la dottoressa Kurzberg ad uno studio clinico che tra poco ci descriverà per valutare l'efficacia di un'infusione endovenosa di sangue cordonale nei bambini affetti da paralisi cerebrale dai 12 ai 72 mesi.
Today I'll speak to you about our work at Duke investigating the use of a child's own cord blood cells to try to treat the symptoms of cerebral palsy. As you heard well explained earlier today, cerebral palsy is the most common motor disorder of childhood. It affects 2 to 3 out of every 1,000 children born. It's caused by a non-progressive disturbance in the developing fetal or infant brain, which could have a number of different potential causes. And although the primary manifestations are motor in nature, it can affect almost any other area of development, including speech and language, cognition. So it has the potential to impair the way a child interacts with the world and therefore learns and develops long term. This is, of course, associated with an increased risk of mortality, healthcare utilization, which is a hot topic in the US right now, and overall societal costs. And as you heard this morning, current therapies are really supportive in nature. There are no existing treatments that are aimed at modifying the underlying cause of the condition. So our group has developed an approach to try to develop novel treatments for children and potentially others with brain injury. I'll touch only briefly on the first two, which are to demonstrate the efficacy of allogeneic, so donor cord blood transplantation in children with certain inherited metabolic diseases. These are genetic diseases. Then move on to perform preclinical studies of cord blood in animal models of brain injury. And I'll focus mostly on these middle two, which are to demonstrate the safety of an infusion of a child's own cord blood cells, and then perform a randomized controlled trial to determine if it helps, essentially. And then ultimately, we'll apply what we've learned through all of those steps to expand potentially to other sources of cells and to other neurologic diseases. So our work focuses on the use of cord blood cells. And the reason that came about is through our experience in using donor cord blood cells for transplantation in children with metabolic diseases. So we know from that experience that cord blood transplant can improve the neurologic function and extend life for decades in children with certain genetic diseases. These photos here are sections of the brain of a child who had Krabbe disease, which is an inherited disease where your brain doesn't myelinate properly. She received a cord blood transplant from a male donor and then died a year later of unrelated causes. But so what you can see, well, it's hard to see. But in these pictures, the blue stains the nucleus of the cells, and these tiny little blue dots, which are hard to show up, but are Y chromosomes, which means that there are donor male cells engrafted throughout the brain of this female patient. So we know that cells given intravenously can make their way to the brain, and that in certain conditions they can engraft there and stay there long term. So from this experience we thought, well, maybe, although for these diseases the cells have to stay there and produce enzyme to make an effect, maybe they could also help induce repair of children who have brain injuries, not metabolic diseases. This has been looked at through many, countless animal models of brain injury, some with stroke, hypoxia, trauma, and many demonstrate benefit of cord blood cells in both neurologic outcome and overall survival. We collaborate with a group in Chicago who has a rabbit model of hypoxic injury at birth, and those rabbits go on to develop cerebral palsy. So he gave cord blood or a control placebo injection to these rabbit pups at about 24 hours after birth. And this is the MRI, which you can see here. This is a control animal. Nothing really lights up. You can't see anything here. This is the animal treated with cord blood cells. You can see here these cells were labeled so they can show up on MRI. You can see they get to the brain 24 hours later. When they get there, we don't know, but we know they're there 24 hours later. And over here, you see these animals treated with cord blood cells are the purple line. And so those animals have less spasticity, they walk better, they have less dystonia than the animals who got control injections. So based on that and a wealth of other animal data, we hypothesized that the same might be true in children with cerebral palsy. The first step was to assess the safety and the feasibility of the procedure, like we heard this morning in a phase 1 study that we started in about 2004. Children treated in this group primarily had either cerebral palsy or congenital hydrocephalus, which is enlargement of the ventricles in the brain. These patients were self-referred or referred by their treating physicians. They voluntarily traveled to Duke for evaluation and infusion from all over the world, actually. And most of their cord blood units were retrieved from private cord blood banks and shipped to Duke in the frozen state. Their cord blood unit had to meet certain criteria, which maybe we won't get into all the details, but we have a minimum dose threshold of at least 10 million cells per kilogram. They have to be free of infection, and we confirm their identity via HLA testing of both the unit and the child to make sure it is indeed the child's unit. It means they have to have a test sample of the unit available to perform that testing. The infusions are performed in the outpatient setting. The cord blood unit is thawed and washed and resuspended per standard procedures in our stem cell lab. The child is given a dose of Tylenol, acetaminophen by mouth, a dose of Benadryl or diphenhydramine, and a steroid through the IV. And those are all given to try to prevent an allergic reaction. And then the cells are dripped in over gravity over about 15 or so minutes through the peripheral IV. And the child stays and is monitored and gets IV fluids for about 2 or 4 hours after the infusion. So for those first 5 years or so, we received more than 2,000 inquiries for the procedure, only about 10% of whom were actually eligible to undergo an infusion. And that's for a host of reasons, mostly because they didn't have their own cord blood cells available, or there was some exclusion criteria that the patient met. So in total, in that period, there were 184 patients and 198 infusions, with a median age of 2 years, but ranged from less than a week old to 9 years of age. We've since done babies who are only a few hours old, up until about the age of 15. The infusions were overall very well tolerated. 3 children had infusion reactions, which consisted of hives or wheezing. And this is presumed due to an allergy to DMSO, which is a chemical used as a preservative when the cord blood cells are frozen so they don't break open. And this chemical is washed out as much as possible, but you can't get it all out. So the children all get a little bit of DMSO. And it doesn't do anything in the body, but the way the body gets rid of it is by breathing it out through the lungs. So it causes a funny smell on the breath. And in addition to sometimes causing an allergy in the child, there was one mother who developed an allergic reaction with hives, presumably, as the child was right next to her and they breathed out the DMSO onto her. She also was very easily treated with Benadryl. We test all of the cord blood units thoroughly, and 14 had a positive post-thaw culture. So they all had to have negative cultures before we would consider using them. But then even if they were all negative, about 7 or 8% had positive cultures when we tested them at the time of thaw. Despite that, all the children did well, and none of them had any clinically apparent infections. So based on that experience, we determined that the infusion of a child's own cord blood is safe and feasible in young children with acquired neurologic disorders. And anecdotally, many of the parents report improvements in their children. But as what it is verbal reports from the parents. So it's hard to know if the improvements were due to the cells or not. Particularly because, as you know, children with cerebral palsy will continue to improve on their own as time goes on. So because of that, we thought it was necessary to do a randomized control trial to determine if the cells are beneficial. So this is called the Cerebral Palsy Autologous Cord Blood Study. It's open to children who are ages 1 to 6 years old, who have cerebral palsy within a certain severity range. So the GMFCS score is what we use to determine that. It goes from levels 1 to 5, and so we accept children who are levels 2 to 4. So kind of middle of the road, excluding the most severely affected and the least severely affected. Or if they have hemiplegia, they have to use their hand as an assist only. They can't have any major comorbidities, so don't require any support to breathe, don't have intractable seizures, and they have to, of course, have their own cord blood unit available, which is a stumbling block for a lot of the children. And that has to meet the same criteria described before. So this is a randomized, double-blind, placebo-controlled crossover study. What that means is children undergo screening by phone because most of them come from a great distance. We get medical records, cord blood reports, and actually video of the child to determine what their functional status is. Their cord blood unit is screened and shipped to Duke in the frozen state. Identity is confirmed via HLA testing, and then they come to Duke for a qualifying visit to make sure no exclusion criteria are realized that we couldn't do long distance. They're then enrolled on study and randomized to the order in which they receive placebo and cord blood infusions. So half will get cord blood infusion first, half will get placebo first. They do that at their first visit. They come back a year later, get the opposite infusion, and then come back one more year and have their final evaluation. And so our primary endpoint is how much they change in that first year to compare the group that got cord blood with the group that didn't. The evaluation is extensive. It takes 4 days to complete. It consists of a neurologic examination by either a neurologist or a developmental pediatrician, quality of life assessments via questionnaires and interviews, imaging via MRI with DTI, which I'll describe in a moment, and lots of therapy evaluations. So primarily, our primary endpoint is a physical therapy, gross motor function endpoint, but they also get occupational therapy studies, speech therapy studies, and a cognitive evaluation each time they come. So as I mentioned, children with cerebral palsy will continue to progress and gain function as they grow. They just do so differently than their unaffected peers. So assessing change above change that would be expected is a little bit challenging. So we chose our outcome measures with that in mind. We used 2 main measures for gross motor function. One is the gross motor function measure, and the other is the Peabody developmental scales. The gross motor function measure is specific to children with cerebral palsy. It ranges in severity, like I said, from level 1, which is virtually no restrictions, to level 5, which is someone who requires maximal assistance. And the nice thing about it is that it has what's the equivalent of growth curves. So anybody who has kids knows that they're supposed to follow a normal pattern of growth, and at any moment in time you can see what percentage they are on their growth level, how, what percentage their weight is among other peers their age. The same is true for the GMFM. So based on how old you are and what level you are, there's a known rate of progression over time. So you can make some predictions about where a child is at one point and where you expect them to be a year, 2 year, 3 years later. We are still enrolling patients. This data was compiled after the first 48 patients were enrolled. We've enrolled a total of 58 at this stage. So when the first 48 had received a total of 80 infusions, meaning part placebo, part cord blood, this is what the group looked like. So there were more males than females. As far as the degree of their cerebral palsy and the typography, almost half had hemiplegia, so one side of the body affected, and then the other half had both sides of the body affected, some with all 4 limbs affected and some with just 2, spastic diplegia. The kids with level 1 GMFM level are the children with hemiplegia, and the rest are kind of split between the other levels. The average age at study entry was 2 years. Most were younger than 3. And interestingly, a quarter of our patients came from out of the U.S. in order to participate in the study. There were a total of 2 infusion reactions, both hives, both easily treated with some Benadryl, 1 positive culture on a cord blood unit. That child did fine, and no apparent infections or side effects. We are still, like I said, enrolling patients, so we don't have final outcome data, but we have seen some interesting images on our MRI scans. So these are the corticospinal tracts, which are the nerves and that connect kind of the motor parts of the brain down through the spinal cord. These are what they look like in a healthy adult. This is obtained with MRI via DTI. It's diffuser tensor imaging, which is just a new technique in MRI imaging. And these are what they look like in 2 of our patients at baseline. This is a patient with quadriplegia, so you can see they're much, much thinner and kind of a little ratty looking. And this is a patient with hemiplegia, so you can see on the unaffected side, it's essentially normal in caliber, where on the affected side, again, it's much thinner, and the projections are not as good. This is a child who entered the study at 16 months of age. He had hemiplegia, and this is his baseline scan. The colors just represent different directions of the neural pathways. But you can see on his regular scan, here is his area of injury, over here. Corresponds up here to this section that looks, as you can see, even with the poor image quality, just not quite as full as the other side. And this is his scan 1 year later, 2 years later, at the end of the study. And you can see he's had an overall increase in white matter, which is totally expected for a child of that age. Their brain continues to grow and develop. But also, this area has filled in. And you can see more green fibers over here, which is in the anterior posterior direction, indicating that those tracts may have, changed direction and filled out a bit. We hope we'll see that that correlates with an increase in function. So that is kind of the state of where we are with our current study. We have additional studies going on at Duke. One for full-term babies who are born with hypoxic ischemic encephalopathy, which is essentially birth asphyxia. So those babies, if their cord blood can be collected at the time of their birth, they all undergo cooling, which is a known therapy for HIE, where they undergo whole body cooling to try to bring the body temperature down to decrease the amount of inflammation and injury. But in this study, they also get infusions of their own cord blood. This time, the cord blood is fresh. It's not cryopreserved. It's just processed and given back to the child. And babies have gotten their first infusion within 6 hours of life, some of them. And they can get repeated doses depending on how many cells are available. That study is completed, and I think 21 of the patients have completed their more than 1 year of follow-up. And the primary purpose was to determine safety and feasibility, and so it is safe, but it also preliminarily shows benefit in both survival and function at a year of age. An additional randomized study is planned to try to confirm that finding. And we're also studying babies with congenital heart disease on life-saving bypass machine, essentially. Babies with congenital hydrocephalus, giving them their cord blood back. They typically get repeated doses because they're small enough that they have enough cells available for that. And then we're also attempting to collect cord blood from premature babies because, as you heard this morning, they are increasingly susceptible to brain injury. But their cord blood typically is not routinely collected. So we're working on that as well. So in summary, cerebral palsy is the most common motor disorder of childhood. There are no therapies aimed at treating the underlying cause of the injury. Cell therapy may have a role in the treatment of cerebral palsy and other neurologic conditions. The study we're conducting should determine if an infusion of a child's own cord blood cells given one time can improve children with cerebral palsy, and the initial results are encouraging. And if there is a definitive positive result, it could change the way we both approach cord blood banking and the treatment of neurologic diseases in general. It takes an enormous team of people to make a study like this or happen or to develop any sort of therapy. And so these are the folks at Duke who work with us to make it all happen.